Hi, this is Dr. Reber, and I'm here to talk to you about septic shock. But to talk about septic shock, we have to start earlier because there's a whole continuum that starts from SIRS and goes through sepsis, severe sepsis, and all the way through septic shock. So we're going to take a look at that and try to get an understanding. So let's start with a foundational concept that we're going to use a lot. You'll use it for the whole rest of your nursing career. If you don't already know about this, it's time to know about this. We're definitely going to use it for the whole rest of this course, and that is the concept of SIRS, Systemic Inflammatory Response Syndrome. I feel like I have SIRS a lot of times, like I'm just systemically inflamed. I got like a lot of inflammation going on. I think my cortisol levels are high, but that is a conversation for another day. So, what is SIRS? We got lots of patients with SIRS. This is an exaggerated immune system response to an insult. So it could be like an injury or just a stressor. I think that's what mine is. But so hopefully you watched the little video that came right ahead of this so that you can kind of have, I don't want you to memorize all of these different bradykinins and serotonins and interleukins and cytokines and complement cascades and all of these different things. But I want you to have an idea of how very, very complex and cascading this system is. So when the immune system gets rolling, there's just a cascade of events that starts to happen. And one thing triggers another thing, triggers another thing, triggers another thing. Now, if you were to have a localized inflammatory response, that's one thing. And then it brings a bunch of mediators are released and it starts bringing your white blood cells to the site. And then what are these leukotrienes and bradykinins and stuff going to do for you? Well, let's bring some heat and fluid to the area to make it easier for these white blood cells to get over here and identify these pathogens, tag these pathogens, eat these pathogens, break them down, clear out the debris. Okay, well, that would be good in a localized area, but what if the thing that is annoying your body or the injury that you're having is systemic? What if it's gram-negative bacteria and they are just circulating all throughout your endothelium and just scraping it up inside, and they're bothering your endothelium of every single blood vessel in your body, including the inside of all your coronary arteries? Well, then this inflammatory response is happening everywhere throughout your pulmonary circulation, your coronary circulation, everywhere. So we got this inflammatory response just cascading throughout your entire body. And there should be a regulation that's occurring, like a feedback mechanism saying, whoa, slow down, too much. But sometimes it's too much inflammation and we get dysregulated and we get what's called a cytokine storm, where now there's so many histamines, so many white cells traveling so many different directions. So some of the big problems that can occur is capillary leak is a very big problem. So we got bradykinins over here causing mischief. A lot of the endothelium becomes activated where there are gaps that start to occur in endothelium, and it's not watertight anymore. And large proteins that usually stay on the inside of your intravascular spaces and hold fluid in with osmotic pressure, those big proteins are now able to leak out of the intravascular spaces into the interstitial spaces. And they're going to pull osmotic pressure out into the interstitial spaces. And now a bunch of fluid that's supposed to be inside your blood vessels is going to go out into these interstitial spaces, which we refer to sometimes as the third spaces of the body. And people get a lot of edema. And now they're intravascularly depleted. So this is a major problem of SIRS. People are all swole up, they're all full of edema, and they are low on intravascular volume. So you can give them fluid, but a lot of it is just going to leak right back out. So sometimes then we give them albumin, right? So we put some big proteins back in the intravascular space, and we hope that they stay in. But one of the other things we do is we give them things like steroids to try to depress this inflammatory cycle, try to cut off some of this stuff. We give them immune suppressors to try to like block the action of some of this like TNF, which hopefully you learned about in that little video, because we got to block some of these cytokine storms and these complement cascades, or else none of this fluid's ever going to stay in the intravascular space. All right. So this is SIRS. It's basically a big hot mess. It's like your body was trying to help you, but now it's just a disaster. So there is a formal criteria. It's not, I mean, there is actually like, you can read a whole paper about it. There's all sorts of clinical guidelines for it. SIRS criteria is you would meet at least two of these things: a very high or a very low body temperature. Let's put a little star by this one. Does this person have a high resting heart rate for no apparent reason at all? I want you to really think about this one. Have you ever come in a room and your patient's not doing anything? They're just sitting in the bed and their heart rate's like 105. What if they're just sleeping and their heart rate is 97? And this is not their normal heart rate. This is above their baseline. So all day long they've been 78, 76, 75. They were sleeping earlier. They were at 62, or they were at 71. They got up and walked to the bathroom. They were at 88. Now they're laying in bed watching TV and they're at 102, 111. Why? Why though? For what reason? When people are at a high resting heart rate for no apparent reason, we have to say to ourselves, why? What is going on with this person? Could it be SIRS? Could it even be early sign of shock? So this is one of the things I always investigate, is when my person is laying in bed with a high resting heart rate. If they have a high respiratory rate for no apparent reason, they're not exerting themselves, they're just laying there breathing fast. Or it says they have blown off all their CO2. So in other words, they have also started to hyperventilate. If their WBCs are very high or very low, or if they have what we call a shift to the left. And we're going to talk a little bit more about this in class. But there's something called bands, which is a type of immature neutrophil. So we have a differential of WBCs on our CBC report, and it will show us these bands are immature neutrophils. So if your bone marrow is starting to utilize and kick out immature neutrophils, more than 10% of your WBCs are immature ones, then you might have an acute infection going on, or like SIRS. All right, so if you meet at least two of the SIRS criteria, then you have SIRS. You have systemic inflammatory response syndrome. Now, the next step is, does your SIRS patient have a suspected source of infection? Then they're probably a sepsis patient. It's likely sepsis. So you want to start asking yourself, are they really septic? Is that what this person is? So your sepsis patients all have SIRS. I really want to say all right here, except for, we shy away from the word all and never. But really, I feel like we could put all there. All of your sepsis patients have SIRS. But there are some people who are in SIRS and they're not actually infected with anything. They're just extremely inflammatory. But all the sepsis patients are in SIRS. I'm hoping that makes sense. All right, so let's move on to sepsis. This is the sepsis ladder. So we do have some clinical definitions of the different stages of sepsis. So we got SIRS down here. Then, what's the definition of sepsis? So if they meet two of these criteria, then they have SIRS, right? If they're in SIRS plus they are confirmed to have a source of infection, or you just highly suspect it, then they're septic. Sometimes you can't get that confirmed culture, but you just know that they're infected. In fact, only about 40% of the time are we going to get a confirmed culture, but we have a diagnosis of sepsis on the patient. All right. And then the next step up the ladder is we're going to call them severe sepsis. So how does it go from sepsis to severe sepsis? This is when we start to see signs of end organ dysfunction. This person is compensated. Their blood pressure looks good. They're neurologically intact. Now, they might have a little bit of a high resting heart rate. Their urine output might have just a little bit started to dwindle off. They might be a little bit tired. Their respiratory rate might be slightly up. Their WBCs might be going up a little bit. But this person in severe sepsis, they are just starting to decompensate a little bit. All right, so what are some signs of organ dysfunction? Let's take a look at some examples. Well, their blood pressure starts to fall. So we know that decompensated shock means that your blood pressure starts to fall, but we're not in shock yet because we're able to correct it with fluids. So we notice their blood pressure starts to go down, but we give them fluids and it stabilizes and they're okay. We're calling this severe sepsis because they're all right. We could do a lactate level on them and it's getting greater than 2. Acute kidney injury. So they're starting to have some kidney issues, like a creatinine that's greater than 2. Or if you're like, well, what if they already had a high creatinine? Okay, well, it's gotten higher. Or you're really noticing that their urine output is going down. Now you're seeing changes in neurostatus. Now their sats are dropping and you're having to put supplemental oxygen on, or if they already had some, you're having to put more oxygen on. Oops. Liver failure. So maybe we get a liver panel and their total bilirubin is going up, or their conjugated bilirubin is going up. Platelet count is getting very low, or their INRs and PTs are going up. Okay, so any organs are starting to fail, and you only need one of these. They're now in severe sepsis. So when are we going to call it definitely shock? All right, so there's a gray area in here where this star is, somewhere between severe sepsis and shock. A lot of people are going to be calling this one septic shock, even if they haven't totally met the criteria over here. So in here is a blurry area between severe sepsis and septic shock. But basically, we're calling it septic shock when their symptoms continue to worsen even though you have tried to stabilize them with fluids. And now they're becoming refractory to your fluid boluses, and they're indications that they are getting worsening multi-system organ dysfunction syndrome. Okay, so more than one of those symptoms of organs are failing. A little bit of fluid is no longer enough to stabilize them. This is definitely septic shock. Now, really important thing about septic shock that sets it apart from all the other types of shock, we know that all the shock you can have a compensatory state, and then they decompensate. So all the shocks can be compensatory and then can decompensate. But septic shock is different because there is a very distinct early phase and a late phase. So we call it the early warm phase, early warm hyperdynamic, and the late cold hypodynamic, unique to septic shock. All right, so what does this look like? If you catch them early, and this is where we can intervene and save them. If we get them late and cold and hypodynamic, the mortality rate is extremely high. So early warm septic shock, there's still like about a 40% mortality rate. But late cold hypodynamic septic shock, 75% mortality rate. Very, very high. That's trying to treat them, 75% mortality rate. So we got to get them in the early phase. All right, so in the early phase, they have a high resting heart rate. So they're going to be probably tachycardic. And you got to say to yourself, why though? Why? They're just laying there in bed. They might even be asleep. So why is their heart rate 104 and they're just laying there? Why is it 97 and they're sleeping? They had a pain med, or yeah, they're just sleeping. Why is it 97? Why is it 105? Go investigate. That's not okay. This is looking shocky. If you are measuring cardiac outputs or cardiac indexes, if you were already doing hemodynamic measuring, it's normal or even a little bit high. Their blood pressure is okay. It's hanging in there. So really it's just probably normal. If you were to feel their pulse, their skin's nice and warm or even kind of hot because they might be febrile at this stage, bounding pulses, brisk cap refill. In fact, it's really fast. It's called a flash cap refill. If you look at their WBCs, they're probably very high unless the person was already immune suppressed prior to this time. And they have what we call a shift to the left, where they have a lot of immature WBCs. More than 10% of those bands of those immature WBCs. Okay, this is early, warm, hyperdynamic septic shock. This is when we want to recognize it and treat them. They still have a blood pressure. If we wait and we do nothing, what's going to happen is pretty soon they're going to start vasodilating. They're going to start vasodilating, and what's going to happen to their blood pressure? They won't have any blood pressure. What's going to happen to their pulses after they vasodilate and they don't have any blood pressure? You won't be able to feel any pulses. What's going to happen to their cardiac output? They ain't going to have any cardiac output. What's going to happen to their cap refill? They ain't going to have any cap refill. Okay, so in the late, cold, hypodynamic phase, also their heart rate will start to come back down. They have compensated for a long time, but their body is worn out and they can't do it anymore. Their heart rate starts to come to baseline or even become bradycardic. This is no good for their cardiac output because not only are they vasodilated with no blood coming back to the right side of the heart, but they don't even have any heart rates. So they don't have any stroke volumes. They have no preload. And so they're going to have low stroke volumes and they don't have any heart rate. So how are they going to have any cardiac output? Blood pressures are very low and falling. Weak pulses, no longer febrile, cold. So if you take a temperature, it's probably below normal, cool to the touch. When you go to get their white count, a lot of times it now starts to fall because basically they used them all up and now they're immune suppressed. Mortality very high on this side of septic shock. So we want to treat them before now. All right, so what are we going to do for them? Well, a lot of times you'll hear terms like early goal-directed therapy or goal-driven therapies, but I'm going to put a question mark on that. So there was something that is very established in the world of medicine that's called the Surviving Sepsis campaign. It was done in 2009. It's been updated like several times. The last time was 2021. It was an international, collaborative, multidisciplinary mega campaign to establish evidence-based clinical guidelines for treating people for sepsis. And it was like super successful. It came up with some great ideas. One of the things they established was this terminology of early goal-directed therapy, EGDT. So everybody adopted that. The idea was you shouldn't just give fluids or try to keep their blood pressure up. You should put in hemodynamic lines and try to establish a cardiac output at this number, a CVP of this number, keep their lactate below this number. So you're trying to hit these numerical goals with the interventions that you're doing. So a lot of sepsis bundles still are goal-driven in this way, but the latest research shows that people don't necessarily have better outcomes if the interventions are goal-directed. So patients definitely have had better survival rates since the Surviving Sepsis campaign. Definitely. Everything got more organized. Everybody started doing the same things. So they started using the best methods. earlier fluid resuscitation, following lactates, knowing when to give steroids, everything got better and more organized across institutions around the world. So it was very successful. However, what are the most important things to do? So the research has been pretty clear that the people with the best outcomes are the ones that they start supporting their blood pressure as early as possible with fluid resuscitation first and vasopressor second. Just go in as quick as you can and don't let them have a long period of time with a low blood pressure. I mean, it seems pretty common sense. And once you get it up, keep it up. Just don't let them have periods with low blood pressure. So fluids and then antibiotics. That's it. And of course, if it's COVID or something, then you want to give the right kind of antimicrobial. So you're giving antivirals if it's a viral sepsis. But a lot of times it's gram-negative sepsis since you're giving the broad-spectrum antibiotic first. If possible, let's try to get a culture and then start the broad-spectrum antibiotic. Because especially if it's like a wound or something like that, once you start the antibiotic, you're not going to get a good culture. And later, we'd love to give a targeted antibiotic for that person. And we're going to have trouble growing a culture if we started an antibiotic on them first. But we don't want to delay. If somebody's in shock, we need to give fluid resuscitation and start that broad spectrum antibiotic. This is what saves people's lives. And remember, we always fill them up with fluid first before we start a vasopressor. They're probably going to get at least like 40 or 50 mLs per kilogram before we start vasopressors on them. And we'll have 2 arms with fluids going in. They'll probably end up getting a total of like 80 to 100 mLs per kilo of fluid resuscitation. So what are the final details? Okay, so we're doing fluids and we're starting broad spectrum antibiotics. This is the foundation of sepsis treatment. Try to get a culture before you start antibiotics if you can, but we're not going to delay treatment. In addition, we just support each organ system. So if they're starting to have multi-system organ failure, we look at each system. They don't have an airway? Get them an airway. They can't breathe? We got to intubate them and put them on a ventilator. We gave them fluids and they still have blood pressure. Time to put them on a vasopressor. If you're having kidney failure, we got to address it. So whatever their organ is that's failing, we're going to do whatever treatment we need to support that organ system. We will follow their labs. So we're going to get, a CBC every so often. We're following their bleeding times. We're keeping track of their WBCs. Lactates are a particular focus for this patient. Lactates tell us about organ ischemia because lactic acid is building up when tissues go into anaerobic metabolism. So as more and more tissues and organs are not getting enough oxygenated blood, lactate builds up. As we get oxygenated blood back into systemic circulation, lactate clears. So lactates don't tell us about inflammation, they tell us about tissue hypoxia. But we're also following inflammation labs. So we want to look at a couple of those labs that tell us about levels of inflammation. And of course, we're following white counts. We got to find the cause. Where is the source of infection? If it's from a wound, they might go in for like a procedure or surgery. It might get debrided. We got to target the antibiotics. So if we could start broad spectrum, but we got a culture. Once that culture grows, we'll switch over to a targeted antibiotic. Consider IV steroids. If they're in tremendous SIRS, steroids are the best anti-inflammatory that we have. And then let's get some hemodynamic lines into this person, like a PA catheter, arterial blood pressure, an ART line. And because if they're like super vasodilated and we have them on vasopressors, like cuff pressures are meaningless. These are not real blood pressures on this person. We need internal blood pressure monitoring and we need to get some cardiac outputs. You can only get these through internal hemodynamic monitoring. we're going to be given some heavy-duty drugs like vasopressors. They need to go through central lines, not peripheral IV lines. Choosing the vasopressor. We know some different drugs that we could give. So we learned several different choices to vasoconstrict the patient. Some of the things we might think of, are they in the early phase where they're pretty responsive to drugs? Levofed is probably going to be the choice. So dopamine right now is not as favored because it can suppress the HPA axis, which controls like your pituitary and your adrenal gland. And these are responsible for your stress response. And that can actually hurt somebody's immune system over time if they're going to stay on a drip. So Levofed, are they in the cold stage where they're very refractory to like almost any drug and they're not responding to anything? They might go right for an epi drip. Or maybe 2 vasopressors. So like Levofed and epi, or vasopressin and epi. All right, I think that's everything I wanted to tell you about SIRS to sepsis to septic shock. So I hope it was helpful, and I will see you in class.